I'm Dr. Kristen Adorno. I'm coming from Christiana. I did train at Cooper, so if this lecture goes well, it's all because of these guys. So today we're going to start off the day. I'm so excited to start off this conference with you all. We're going to be talking about the dreaded and often overlooked right ventricle. So my goal today is going to be looking with you guys through the pathophysiology of the failing right ventricle and making you feel empowered about seeing your next patient in acute right heart failure and not feeling overwhelmed and not understanding what's happening, but actually having specific pathophysiology-guided treatment patterns that you can use in order to resuscitate your patient. Let's see. Okay, so I have no financial disclosures, but my only disclosure is that I am an emergency physician. So the acute right heart failure that I am most comfortable with is that of the massive pulmonary embolism. So we're going to talk about a case today. This is going to be a 42-year-old female who's coming to your emergency department with just 2 hours of acute onset pleuritic chest pain and shortness of breath. She has a history of hypertension, tobacco use, and she's been previously pretty healthy, but she had a trimal of her right leg just a couple weeks ago and recently underwent a right ORAF. She's been having some leg swelling for the last couple days, but didn't really think much of it. She thought it was kind of from the boot from her surgery. But she's coming to you looking acutely unwell. They bring her directly to her room, and these are her vitals. She's tachycardic. She's hypotensive. She's tachypnic. She's hypoxic on room air, and she's afebrile. You go in the room, you start your initial ABCs, you get her on the monitor, you do your EKG, Acute check, you have nurses work on access, and you throw the probe on the chest as soon as you're talking to the patient, and you're concerned that you see exactly what you were dreading, a dilated right ventricle. You throw it into peristernal short, you're worried that you see some septal flattening, and then you look at your apical forechamber, and all of your worst fears are confirmed, and you are very afraid that this patient is actively dying in front of you from a massive pulmonary embolism. There's a lot of other ultrasound findings you can go into that unfortunately are going to be outside the scope of this talk today. But from your clinical gestalt and also from the fact that this is a lecture on acute pulmonary embolism, you are highly suspicious that this patient is suffering from a massive PE. So you need to realize that this patient is not going to be resuscitated the way that your normal patients in shock are going to be resuscitated, because this is a failure of the right ventricle, whereas most of the time it's the left ventricle. So rather than being overwhelmed by these patients, I think if you really understand the pathophysiology of what's happening to them, it's a lot more easy to resuscitate them and feel confident doing so. So we're suspicious that this patient had a DVT that embolized to her pulmonary vasculature. This is going to cause an acute rise in the pulmonary vascular resistance. And the right ventricle is not equipped with handling high pressures. So this is going to cause an acute dilation of the right ventricle. The right ventricle, when it's dilated, it doesn't contract well, and that's going to cause decreased output of the right ventricle. And less blood coming out of the right ventricle is going to mean less blood coming into the left ventricle, which is going to decrease your left ventricular preload. This is going to cause a drop in your cardiac output, which is already going to be diminished because that right ventricle is pushing onto the left ventricle, and since the heart is in a finite space, it's already going to have a decreased diameter to work with. So you're going to have a decreased cardiac output, and then once your patient is no longer able to become tachycardic and compensate, they're going to start developing systemic hypotension. And we know that when your patient is hypotensive, all the major organs don't get perfused well. Specifically, your right coronary arteries are not getting as much blood flow. And that's going to cause worsening ischemia of your right ventricle, which is going to feed right back into this cycle, and so on and so forth down your downward death spiral of the right ventricle. Eventually, it'll lead to cardiogenic shock and death. So I want you to keep this picture in mind as we go forward with the lecture and we talk about ways to resuscitate this patient, because everything we talk about is going to feed directly into this pathophysiology. And it's actually, I hope I demonstrate that it's a little bit more simple than you think, because I know, at least when I was training, I used to be very overwhelmed by the right ventricle and I didn't understand it. So that's why I really want to explain things to you, that it's really doesn't have to be difficult if you really think about what's happening to your patient's heart. Let's talk about management. So oxygen is actually the best vasodilator for the pulmonary vessels. So on the flip side, hypoxia and hypercapnia are actually going to be pulmonary vasoconstrictors. So really you need to be diligent about avoiding hypoxia and hypercapnia in these patients. Your mainstays of treatment are going to be your normal high flow nasal cannula and BiPAP or CPAP, or BPAP as Handy says it. And there's normal dogma, right, of you're not supposed to intubate these patients. And that's completely true. And I think if you think about the pathophysiology, it makes a lot of sense of why you want to avoid intubating these patients. So going back to the death spiral that we just discussed, what are your normal things that happen during intubation? You're at risk of your patient becoming hypotensive since you're reversing their pathophysiology, you're causing increased thoracic pressure, and that will inherently drop the patient's blood pressure. Furthermore, we're giving them sedating medications that will usually drop their blood pressure as well. So by causing more hypotension, you're directly feeding into that spiral. Furthermore, we know that when our patients are being intubated, they're at risk for hypoxia, and they're probably more at risk for being overbagged in between attempts or right after, and having increased tidal volumes on the ventilator, all of which will cause worsening pulmonary vascular resistance and worsening your PVR, which is going to feed right back into that spiral. There are some cases we all know where even though you're not supposed to intubate these patients, sometimes you have to. So sometimes they just arrested and their mental status can't handle it, or sometimes their work of breathing just isn't enough to compensate. So if you really need to intubate these patients, which sometimes you do, there are things that you can be mindful of to make it as safe as possible. This is going to be the time that you're going to want to do your most hemodynamically neutral intubation as possible. So this is the time when I'd actually suggest using ketamine rather than your normal other agents that you would use. I would also consider putting your patient on vasopressors if you haven't already, and increasing your MAP before you do it. So instead of titrating your MAPs to 65, maybe making their systolic blood pressure like 120 or their MAP around 80 so that you've got room to go down during intubation. I would even consider having push-dose vasopressors in the room so that if things start deteriorating during your intubation attempt, you're able to quickly compensate for that. Avoid hypoxia. So for any of my residents who are here listening, I'm a big fan of letting anyone try their attempt at intubation, but this is probably not going to be your July intern intubation. This will be an intubation that you really want to have one of your more experienced providers with their more preferred methods so you can avoid hypoxia as much as possible. And then lastly, be really mindful of the excessive pulmonary vascular resistance whenever the patient's being overbagged. So if the lungs are overdistended, it's going to cause increased vascular resistance. So namely, when your RT is overbagging, or you or anyone's overbagging, either in between attempts or right after, that'll increase the pressure in the chest and increase your PVR. And also when your RT is setting your ventilator settings, just be really mindful of keeping them on lower tidal volumes, since a larger volume is also going to worsen your PVR, which we all recall from that death spiral is just the first step. So there's more resistance that the RV has to push against. So really being mindful of each kind of step of that process. We all know that right ventricle is preload dependent. So we say, oh, they're in right heart failure, we have to give them fluids, they're preload dependent. Think about what's actually happening. So this patient is coming into you, you're a normal person, she's living her life, she had recent surgery, she's recovering well. She's not having vomiting, diarrhea, most likely, as long as there's not something else going on, there's no reason that she's volume down when she comes into you. She's coming in with chest pain for the last couple hours. So these people who are just kind of walking around living their life and start having chest pain are probably mostly euvovolemic. Now I know it's really hard for someone to come into the emergency department hypotensive and not get fluids hung right away. But I would be really judicious about giving these people fluids, because if you give them excessive fluids, that's only going to further dilate that right ventricle. And going back to that diagram, if you dilate it more, it'll contract worse, and you're going to have worsening right ventricular output. So more fluids is not going to be more helpful for their blood pressure. I'd argue that you really shouldn't give any more than 250 cc's or 500 cc's of fluid unless you have some other reason to think that they're volume down. I would be really quick about starting vasopressors for these patients. So after you've tried 250 or 500 cc's of fluid and nothing's really changing, transition to pressors, and your normal vasopressors will be just fine. Norepinephrine is a very reasonable choice. There's some data that suggests that epinephrine is probably a better choice for these patients, but either of them is fine. I would just prefer that over fluids for any of these patients. And then your second line agent, vasopressin, is actually a really nice second choice for these patients, just keeping it at a low dose, like a fixed rate, it's like 0.03. Because at those lower doses of vasopressin, it does cause peripheral vasoconstriction, but it actually avoids pulmonary vasoconstriction. So it won't further worsen your PVR. And then you really want to be diligent about avoiding hypotension, because like we said, that's really kind of the last spin of the death spiral. So If you're at your point of second pressors, you can always consider inotropes, since the last part of this failure is going to be cardiogenic shock. And I know, at least in the emergency department, we're all very afraid of inotropes like milrinone and dobutamine, but they're actually reasonable choices for patients like this when they're really spiraling. I probably would do this in consultation with the intensivist or cardiologist or the rest of your team members on board if you're past your second pressor and talking about inotropes. But just know that those are reasonable choices as well. Other things that I feel that we're a little bit intimidated about in the emergency department that you might want to do in consultation with another specialist, but talking about inhaled pulmonary vasodilators. So the first part of that death spiral we talked about is the increased PVR, the increased pulmonary vascular resistance. So these are actually pretty safe medications that you can give that will directly act on that, and it'll dilate your pulmonary vasculature. There's been equal data showing that epoprostenol and nitric oxide, both inhaled agents, are pretty safe and don't cause systemic hypotension and will cause just direct vasodilation of your pulmonary vasculature. And it's actually really good. These agents have shown good efficacy in improving not only hemodynamics, but oxygenation and your VQ mismatch. So if your patient is on high flow or BiPAP and they're still hypoxic, the move is not going to be intubating them. If they're still hypoxic, you can consider something like that. And this might actually save your patient from intubation or might be something to consider peri-intubation. And then thinking that it's an acute PE. So hopefully at this point we've resuscitated our patient enough to get them down to CAT scan to really confirm that this is a PE, because I'd be a little hesitant about giving full dose TPA to someone that I wasn't sure. But now that we know that that's what's going on, we have to treat it. So we want to bust up that clot. Now, there's some data out there that you can give half-dose TPA for massive patients, and this is not really mainstream yet. There was one article by Wong et al. In 2014 that did a randomized control trial showing that there was somewhat equal benefits of giving half-dose TPA and full-dose TPA for massive, specifically PE patients, and did definitely have a lesser adverse effect profile. Because as we know, when we give full-dose TPA, there's a very high risk of life-threatening hemorrhage in these patients, specifically intracranial hemorrhage. So the thought is, if we give less TPA, can we still save our patient without causing them a very high risk of massive intracranial hemorrhage? The rest of the data doesn't fully support that just yet. There was another article more recently in 2018 that did show that if you give half-dose TPA for these massive patients, they do need repeated dosing. And they're often more at risk of death or harm if you don't fully treat them up front, even though they do agree that there are less adverse effects by giving the half dose. So right now, it's definitely not mainstream to give half dose TPA for massive PE patients. There's definitely, hopefully, more literature on the way talking about it, because it would be reasonable to suggest that this could be a weight-based dosing. So if you do have a patient who's less than 65 kilos or at very high risk for intracranial hemorrhage, it might be worth talking with the family and engaging in shared decision-making about talking about half-dose TPA. But right now, all of the major guidelines and governing bodies do support you using full-dose TPA. So I wouldn't really jump the gun about going half-dose just yet. But I'm hopeful that one day we can talk more about it. And then heparin. So as soon as this patient hit the door, when you were concerned about PE, as soon as you put that probe on their chest and you saw their dilated right ventricle with that great story, it's very reasonable to start heparin right away. So doing your full heparin bolus and drip. And if you've already started heparin, this should not deter you from doing TPA. There's some data suggesting that you can pause the heparin drip when you're giving TPA and maybe have it paused for the first 2 or 3 hours just to minimize really anticoagulating your patient at the same time, and that has some data that it'll slightly decrease your risk of intracranial hemorrhage. But definitely heparin up front and then TPA once you know what's going on. Some additional things you can consider. So catheter-directed thrombolysis is really more commonly used in your submassive pulmonary embolism patients. It obviously is very beneficial because you're giving directed TPA right into the pulmonary vasculature. So it does have a lower risk of intracranial hemorrhage and life-threatening bleeding. But the problem with it is your patient needs to be stable enough to get down to the cath lab, and you have to be at an institution that has a specialized center that's capable of doing it. So that's why they're usually, at least from my experience, the institutions I've worked, usually They're more eager to take a patient when they're more stabilized, so more in a submassive PE picture. But if you have a patient who is really not able to get TPA, like if they've had a massive bleed recently or they'd be very high risk, it's worth talking to your consultants to see if this could be an option. Along the same lines, surgical embolectomy is another option for people who are not candidates for TPA or who have failed TPA. But again, it does require a specialized center and a willing consultant to do it. ECMO, same deal. You need a specialized center, but this is a great choice for these patients. So the patient we talked about, that 42-year-old female who was otherwise pretty healthy and is now actively dying in front of you, this would be a great patient to talk to your ECMO team, or if you're not in an institution that has ECMO, considering transferring them. I have friends who cannulate and work with ECMO, and I know Haney and people would agree that they want you to get them on board as early as possible, because as soon as you've pushed TPA, if you're now asking your consultant to cannulate them, they're not going to be super excited about it. So as soon as you have this patient who's not doing well, really talk to them up front about ECMO. If at any point during your resuscitation, your patient does unfortunately lose pulses, and you've either already confirmed that they do have a massive PE or you're just very strongly suspicious, it is reasonable to give TPA during cardiac arrest. And the data does support doing 50 milligrams of TPA, just doing an IV push during arrest, and you can do it up to twice. There's actually, there's a study out there that does show pretty good data about getting the patient, getting ROSC after giving TPA in known or suspected PE. So let's finish up with our case. So back to our 42-year-old female. So she comes in hypoxic, we said, to 81% on room air. We immediately get her on BiPAP, and her SATs do improve, as does her work of breathing. She, of course, gets half a liter of fluid because, like I said, it's hard to stop anyone from giving fluids, either in EMS or when they get to the ED. We're all tempted to do some, but it doesn't really change much. So we immediately start her on a norepinephrine drip, and we titrate her MAPS to 65, and her heart rate steadily improves. We finally get her stable enough to go down for CTA, which does confirm a saddle pulmonary embolism. She does get full dose TPA, the bolus and drip over the 2 hours, and then she's eventually brought to the ICU, and she steadily improves from there and theoretically lives happily ever after. So the final takeaways I have for you all, if you remember nothing else from my talk today, here's just a few key points. So with your patients with acute right heart failure, avoid hypoxia and hypercapnia and be very diligent about it, and avoid intubation if you have to, if you're able to. If you really do have to intubate them, just be mindful of keeping it hemodynamically neutral, considering ketamine, using your most preferred approach, trying to avoid hypoxia and trying to avoid overbagging, and having a very dilated tidal volume after the intubation. Be very judicious about giving fluids and be very quick to starting vasopressors, and make sure that you avoid hypotension in these patients. And in that line, if you're moving forward with your vasopressors, if you've done full dose norepinephrine or epinephrine, you're moving to vasopressin and things still aren't going well, think about inotropes. And then also think about pulmonary vasodilators, specifically if your patient is hypoxic and not improving with your initial measures. After CPA, it's not really mainstream yet, but hopefully keep an eye on the literature that we might have some more data coming, and just consider it if your patient is usually less than 65 kilos or has very high risk of bleeding. And then talk to your ECMO team as soon as possible, as this might be a great option for them. These are some of my references, and that is all I have for y'all. We're going to do the next 2 lectures, it sounds like, and then we'll do a little breakout group afterward. So if you have any questions, feel free to just write them in your phone and save them for me, and we'll all answer your questions afterward. But thank you so much.